All right, here we go. Chapter 16. All right, talking about, all right, treatment of arrhythmias can involve medications, electrical shock to the heart, electrical stimulation to pace the heart. All right. So if you keep in mind that that all atrial rates should be defibrillated to convert them back over, you will hear me refer back to some different chapters. Please be sure that you guys go back, read over what I referenced to refresh and bridge the gap between the material. Okay, it's the only way we're gonna be successful if we do our part to connect the dots on everything. All right. So arrhythmias, uh, excuse me, antiarrhythmics used to prevent and or treat arrhythmias. They affect the action potential. Okay? There are four classes. You have class one, which are sodium channel blockers. Class two, which are your beta blockers. Class three, potassium channel blockers. Class four, calcium channel blockers. And if you go back and look at the very beginning, chapter two, we talk about the transfer of sodium and potassium throughout the body, with all that's being done while the heart is pumping, which leads to the various things that we see: too much calcium, too much potassium, as hyperkalemia and things of that nature. All right, so you can go back and read that over in chapter two. All right, so your class one sodium channel blockers, they block the influx of sodium into the cardiac cell during depolarization. All right, they affect phase zero of the action potential. Class 1A, quinidine, procanamide, cause prolonged QT intervals used to treat ventricular and supraventricular arrhythmias. They also have lost flavor and current practices, which means that not too many people are using them anymore. All right. Before I go to the next slide, I just want to remind you all about the post that I made yesterday with the different classes of drugs on there. I want you guys to refer back to that often to help you remember the drugs and which categories they fall in. They give you some little analogies and things of that nature, little synonyms to help you remember. Find that to be extremely helpful if you utilize it. Right. So we have the class B, having lidocaine, tocanide, which is the treatment of ventricular arrhythmias only. You're only going to use lidocaine and tocanide to treat ventricular arrhythmias. Okay, they suppress the ventricular inability to rise a fibrillatory threshold. All right, class 1C, fluocanide, propafenone. They slow the impulse conduction. They treat SVT and ventricular arrhythmias, prone to causing arrhythmias, used only in life-threatening situations. So you have class 2 beta blockers. Beta blockers slow the heart rate by blocking sympathetic nerve system, um, sympathetic nerve system beta receptors. Beta 1 receptors increase the heart rate, conductivity, and contracticity. Beta 2 receptors relax smooth muscles and arteries and bronchi. to continue on with that, they're used to treat supraventricular tachyarrhythmias. They depress phase 4 of the action potential. Example, um, propanol and metoprolol. Class 3 potassium channel blockers. They interfere with the movement of potassium into the cardiac cells during phase 3 of action potential. Can cause prolonged PR, QRS, and QT intervals. These class 3 potassium channel blockers are used to treat ventricular and supraventricular dysrhythmias. Some examples of class 3 would be amiodarone and ibutine, ibutide. All right, so you have your class 4 calcium channel blockers. Okay, they interfere with influx of calcium into the cardiac cell during phase 1 and 2. They slow phase 4 of the action potential. They can cause prolonged PR intervals and slower heart rate. They're used to treat ventricular arrhythmias. Examples, um, verapamil and deltiazine. All right. So here we are. You see what the action potential looks like when you refer back to chapter 2. Um, when you were first introduced to the action potential, and I'm pretty sure you all know. If you don't know, there's something that we can talk about, how the actual QRS complex lines up with the action potential. It touches on it in chapter 2 also, but again, it is something that we can go over if need be. Um, but you know, the four phases of the action potential, you have 4, 0, 1, 2, 3. Um, and what this chart right here is just showing us where the medications correspond to the action potential and the EKG itself. All right, not the EKG, the QRS complex. All right, um, so we know based off everything that we've learned thus far that certain things are synonymous to certain parts of the heart. If something's going on with the um, and the atria, we'll see these certain things on the EKG, um, and that goes with everything across the board. Depending on the area of the heart, different things will be reflected in the QRS, whether it be um, depressed ST depression, ST elevation, um, inverted T waves, U waves, and things of that nature. It all depends on the area of the heart that the problem is in that will induce those those characteristics to be seen on the EKG. Right. All right. So 16.1 just shows that just breaks all the medicines down into their classes. Shows you their mode of action, examples of the medicines in their class, and the kinds of arrhythmias they treat. All right. So you see here we have class 1 and class 2 of you got your sodium channel blockers, beta blockers. See again that they treat ventricular, supraventricular, and ventricular um, arrhythmias. All right, class 3, class 4, potassium channel blockers, calcium channel blockers, and see examples of those and what they treat. And it's everything that I just talked about is just now in chart form to show you how to just to further expound on that. All right. All right. Other antiarrhythmics medications, you have adenosine, which is used to treat supraventricular tachycardia. Digitalis is a cardiac um, glycoside used to treat heart failure and supraventricular arrhythmias. So now, in the case of an emergency, the medicines we would use a different set of medicines. Um, we have atropine, which increases the heart rate during bradycardia. Epinephrine causes vasoconstriction and beta receptor stimulation. All right. This increases blood pressure and heart rate in asystole and bradycardias. Also used in V-field and pulseless VTEC. All right. One thing that hospitals are doing now, um, in the event that is serious, where epinephrine has to be used, they typically replace epinephrine with vasopressin. Vasopressin, um, they'll use vasopressin first uh, before they result to using epinephrine. Does the same thing. Um, they get their first dose to apply. They do it during cardiac arrest, just to try to help stabilize the heart. All right. Then you have dopamine, increases the heart rate in bradycardia. Right. Amiodarone treats ventricular fibrillation and ventricular tachycardia, as well as supraventricular tachycardia. Adenosine treats supraventricular tachycardia. Sodium bicarbonate decreases acidity of blood during cardiac arrest. Oxygen increases tissue oxygenation during cardiac arrest emergencies. And I just want to point out again just how all these medications revolve around leveling out the potassium and calcium and sodium that that are levels in our bodies. Once our levels get out of whack, that's when we start having these health conditions. Right? So, and there's a method to all the madness. That's why it's important that when we're drawing blood, that we make sure we draw the blood the right way. Make sure we're using the proper tubes, because we know tubes have additives in them, and if we draw the wrong tube with the wrong additive, and it could elevate someone's levels or cause someone's levels to read lower than what they are, and that would be a major problem, because that could result in someone losing their life, because we can prescribe them the wrong medication or suggest a treatment that they don't need. So that's why we need to be mindful of the things that we do. Pay attention to everything. And I know it seems like a lot. So we go through things like really fast. But again, you have to take time out to study and try to gain understanding as to what's going on. Because there's a method to the madness. Everything goes hand in hand. Um, so you just want to be mindful of that. All right. So again, just a summary of the emergency medications. So what they do and what they're going to fix when the time to use them. Um, when is the proper time to use them based off what you see, what symptoms the patient is exhibiting, or what you read on the EKG. Again, let's continue. Right, other medications with EKG effects, they're given for non-EKG related reasons, but have effect on the heart rhythm or heart rate. All right. So some of these other medications include diuretics. They're given to increase urine output in patients with heart failure, um, renal disease, or hypertension. Right? You know that when you go to urinate, you a lot of potassium and things of that they come out in your urine. So giving these medications to increase if your level's too high, giving them a medication that will cause you to urinate would naturally help bring your levels back down. Okay, and um, the downside to it, they can cause dehydration because again, once you urinate, you're taking all that excess um, fluid in your body and it's being pushed out. Um, it can lead to hyperkalemia because you are dehydrated. Now your heart's having to work overtime. Um, so we have some of these medications, some of these diuretics. They are furosemide, butanide, ethylcrinic acid, and Mentanol. Okay. EKG effects. This is what you'll see on the EKG after these medications have been administered. You'll see ventricular arrhythmias and tachycardias. All right. So now we move on to your bronchial dilators. They dilate the narrow airways in patients with asthma or chronic lung disease. All right. Some examples of your bronchial dilators are your albuterol, levobuterol, probuterol, salmeterol, and formoterol. All right. Things that you'll see on the EKG, um, tachycardias, often of the 140 to 150 range, can lead to decreased cardiac output, cardiac ischemia, and chest pains. Right. Antihypertensive antihypertensives given to treat high blood pressure. There are several types. You have your diuretics, your beta blockers, uh, vasodilators. All right. Examples of these beta blockers include uh, ezamol, propranolol, metoprolol, and labetalol. Examples of your vasodilators: hydralazine, nitroglycerin, 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 some T totally different, and deltazine. Right? Try to break that one down for y'all so y'all be able to pronounce it. All right. Now we're on to nitrates, given to dilute dilate the coronary arteries, help relieve chest pain, can cause your blood pressure to drop, resulting in tachycardias. If the blood pressure is low enough for long enough, it can cause myocardial ischemia and or an MI. I don't know why they did that, but okay. Typical examples of nitroglycerin tablets are glaucoma medication. These are eye drops to control the intraocular pressure. Um, some of them are beta blockers. Some of the things that you will see pop up on the EKG are bradycardias. An example of how to treat that is timolol. Right. Erectile dysfunction medications can cause profound hypertension. Right. Some things that you'll see on the EKG. You'll see cardiac ischemia. You'll see tachycardias, MIs, especially if taken along with prescription nitrates such as nitroglycerin for chest pains. Some examples are slat, slatdifenol and tadalafil. I apologize. Sildenafil and tadalafil. All right, so your tricyclic antidepressants, or TCAs, used to treat clinical depression. Things that you'll see on the EKG, bradycardias, including AV blocks, sinus tachycardia, unstable ventricular arrhythmias, asystole, widened QRS, prolonged PR, and QT intervals. Some examples are amitriptyline and doziopen. Right. Effects that we're gonna switch over to the illegal drugs now. Um, Cocaine, antihistamines, and ecstasy. These are always used for to get a buzz. Some things that you will see on an EKG. The person has consumed these drugs. You see prolonged QT intervals, um, predisp- uh, predisposing um, torsides, tachycardias, AV blocks, myocardial ischemia, and coronary artery spasms. All right. The thrombolytics are used to dissolve the blood clot, causing a heart attack or stroke. Can cause bleeding, increased heart rate. EKG effects should cause elevated ST segment to normalize autoplays and tenectoplays. Anticoagulants used to prevent blood clots in patients with atrial fibrillation and other disorders. Tachycardias if bleeding results. Utilizing electrical stimuli. This can be used to speed up or slow down the heart, shock the heart out of an unstable rhythm. Um, they have two kinds of and this is through artificial pacemakers or cardioversion defibrillation or defibrillation. All right. Traditional artificial pacemaker the primary function is to prevent heart rate from becoming too slow. All right. So the purpose of the pacemakers, like I said, is to prevent the heart from beating too slow. Um, the way they're inserted in the heart is to stimulate that area of the heart that's where the problem is originating from. So by providing that impulse, it keeps the heart on track, keeps it beating at the rate at your average heart rate. That's the point of the pacemaker, just essentially just helping it keep pace, providing electrical stimuli to the heart, just what I just said. Your anti-tachycardia pacing is overdrive pacing. Um, just trying to speed it up. Interruption of tachycardia. Okay. So indications that there may be, we may need a pacemaker. Should you be mindful that all of these are things that you would need to remember all these indications. So I suggest you may want to. I encourage you to highlight these in your book. Um, Symptomatic sinus bradycardia, junctional rhythms, idle, I, uh, idle ventricular rhythms, dying heart, asystole, 2-1 AV block, Mobis 2, third degree AV block, or anti-tachycardia pacing. Um, Permanent versus temporary pacemakers. Permanent pacemakers used when a arrhythmia is thought to be permanent. It's implanted surgically. Components is the pulse generator, which is the battery pack, the pacing catheter, and batteries made of lithium. They last to 5 to 15 years. Okay. When I was speaking before that a couple slides ago, when I was talking about the purpose of the pacemaker and why it's in the way it's inserted and the way it works, I was referring to this that pacing catheter is placed in the area of the heart to help um, ignite that beat or start that beat. Right. Um, so and the battery they use lithium batteries. Lithium batteries they have a good shelf life on them. They last 5 to 15 years. When I don't remember if they well anyway they after someone dies with a pacemaker, that pacemaker is going to keep firing, so there will be a heartbeat, so to speak, from a dead person, but it's just the pacemaker, and it will beat until the batteries in that inside the device dies. All right. It's permanent pacemakers to show you what the pulse generator looks like. Um, what the pacemaker looks like when it's inserted into your heart. Okay? Temporary pacemakers they will only be used when the arrhythmia is likely to only last a few days, and that happens. Um, you'll be Everything will be good one day, the next day it's not such a good day. So as we have pacemakers for those instances also. You don't need one that is always going and always actively trying to regulate your heart. You have those ones that the temporary ones that just regulate when it's needed. Um, Most commonly type use are the transveins. They insert into the large vein, threaded into the right atrium or ventricle. Um, the transcontinuous attach attached to skin by way of large electrodes, pulse generators at the bedside. You'll see that on the next slide coming up. All right, this is what the temporary pacemaker looks like. It's the transverse components. See, you have your pacing catheter here, and the pulse generator should be at the side of the bed. All right, transcontinuous pacemaker. So the large, you see the large electrodes that go on the chest, and the pulse generator. All right, so um, pacemakers have a unique, have a bunch of unique components. So you want to be able to understand how they are described and um, how to describe them, what they do. And so you have firing. So generation of electrical stimulus is causes the cause of the pacemaker spike on the EKG. If we go back, I'm pretty sure if we go back, I didn't pull one, an exact one, but we'll see them in this chapter actually coming up. We actually have some practice one that we're going to look at. You will see that dark line indicated on the EKG, and you will know that that is the pacemaker when it should be firing. Okay, you have capture, depolarization of the chamber, being paced causes a P or QRS to follow the pacemaker spike. So you'll see again that what they're saying is you'll see that black line indicating that the pacemaker is firing, um, assisting the heart with the beat, pacing the the beat of the heart, and you have the capture component of it, which is which happens in the depolarization phase, um, and it's immediately followed by the P or the QRS. All right. So you have sensing, this pacemaker's ability to recognize intrinsic beats to decide if it needs to fire. Right? Um, Causes appropriate time intervals between beats on the EKG. So it helps it show that your beats are not overlapping. Gives you allows for a good clean EKG to be presented so you can read it. All right. The code. All right. So pacemakers have a code. The first letter is the chamber pace. All right. So is the problem? Where's the problem originating from? All right. So we have the ventricle, atrial, you have dual chamber, or you have none. All right. Then you have the second letter of that. So it would you have the ventricle, the atrium, dual chamber of or none. The third letter is responds to the sense event. Is it inhabited? Is it triggered? Is it dual, which could be inhabited or triggered, or is it none? All pacemakers in use today are demand pacemakers. The sensor tells the pacemaker when to fire. Okay, so it's on demand. So they've done enough research and got it down to the point where they just know when the pacemaker should fire, and that's the way it's programmed, and that's exactly what the pacemaker does, and it helps keep the heart beating at a steady rate to where the patient is comfortable.